in listen-only mode.
Welcome, everyone. This is Joanne Geer from the Biopharma Research Council. We're very happy to host this webinar this morning on the upcoming Cardiovascular Clinical Trialists Forum. We'll wait just a couple of moments while everyone gets logged in, and then we'll begin. Again, this is Joanne Geer. I am the Executive Director of the Biopharma Research Council. We are a nonprofit association for scientists across all the many silos of biomedical research, and we are really happy to be working with the CVCT Forum this morning to share with you their upcoming program. Just to share a couple of things that we have going on, we've had a very busy autumn. I just got back from our Triangle Biotech Research Symposium focusing on technology convergence. Those recordings will be online in a couple of days. We have also in the queue from the past couple of months, Altering the Microbiome, which was at the National Cancer Institute, Advances in Tissue Imaging, and we have a number of upcoming programs which you'll be informed about through the email. At any time during this webinar, feel free to enter questions. There's a question box on the right-hand side, and we will be addressing the questions after we've heard from all of the speakers. We'll have a nice long Q&A period. And so I'm now going to introduce Dr. Phibes Inaud, who is a co-chair along with Dr. Pitt for this conference. Dr. Inaud.
Yes, hello everybody. I am really pleased to welcome you on board of the CVCT meeting. So I'm now sharing my screen. I hope you can see it. And wow. Here we are. So I would like to share with you the whole concept of this meeting. Can you see my screen? Because something occurred. Okay. This meeting has been founded maybe 12 years ago, and we have started it with Bert and Pitt, who will speak to you later today. And this meeting is totally dedicated to cardiovascular clinical trials. It is organized by university. I am professor of therapeutics and cardiology and clinical trialist as well. And I work at the University of Lorraine and at the INSERM Medical Research Institute in France. So the meeting is going to take place this year in Washington, and okay, I have this funny thing popping up on my screen. I am sorry, and the co-founder is Professor Pitt. He's professor of medicine at University of Michigan School of Medicine. He is typically what we would call a clinical trialist. He's participated in so many clinical trials, mainly in heart failure, and I had the privilege to share with him some of the trials with mineralocorticoid receptor antagonists. You can see here a very short excerpt of his CV and credentials, and he will discuss at the meeting and later today about the hyperkalemia trials and chronic kidney disease, as well as the newest mineralocorticoid receptor antagonist trial. But right now, I just want him to give a very brief thoughts about the history of CVCT and how important to have the various stakeholders and what makes CVCT very specific with assembling PIs, primary investigators, but also as faculty members, industry research and development experts, and also regulators and journal editors. Bert?
Well, thank you, Phibes. Well,
We've been involved, as Fayez said, in CVCT for many years, and over the years it's evolved as one of the most, I believe, exciting meetings for clinical trialists in cardiology. It brings together sort of investigators who are designing clinical trials, industry, regulators, both from the FDA and EMA, statisticians, and it's a wonderful place to hear the latest of the results of the clinical trials and where they're going in the future. But it's also a place where we all learn together how to design better clinical trials for the future. And we've had lots of input, as I mentioned, from the FDA and EMA, and this year we're delighted to have Rob Califf, who's been nominated to be the new head of the FDA, give our keynote speech. So I think everyone will really get something out of this, and we're all looking forward to it. So I'm going to give it back to you, Fayez.
Thank you, Bert. And our next speaker today is Jeffrey Borer, who is professor of medicine in New York. And actually, he's been really supportive and a regular speaker at the CVCT meetings because of his past experience and current experience as investigator of so many trials, but also past experience at the Food and Drug Administration, where he had served as an advisor. So he's typically a great bridge between investigators and regulators. And I would like to ask him, how is it important that CVCT assemble these various types of stakeholders, especially from the regulators, not only from the United States, but also from Europe? Jeffrey?
Thank you very much, Fayez. I think this is an extraordinarily valuable annual meeting, the CVCT Forum, and I have been participating now, I think, since its second year. The point that Fayez is making about the opportunity for a meeting ground for regulators and academicians and others to discuss the issues of therapeutics development is very, very important, because, in fact, regulatory affairs and the principles that guide approval of therapeutics, of therapies for various cardiovascular problems, are very different from the principles that guide academicians and researchers and trialists in developing trials. The opportunity to understand those differences and why they exist and how to meet on a common ground that can lead to the development of better therapies is really one of the major contributions of this conference, and I think that that really needs to go on.
Thank you, Jeff. And our next speaker, and I can see she's now connected, Carrie Lam, joined CVCT actually a few years ago, and she thought that it's really important that this experience is brought to Asia because cardiovascular trials are going, and our Asian colleagues are contributing increasingly to main cardiovascular trials. But she will explain why she thought that we should have CVCT as another meeting in Singapore, so enriching the family of CVCT meetings. And then I will ask her later to show some slides about the regional differences in trials. But just short notice, Caroline, on how important to bring CVCT to Asia first.
Thank you, Fayez. You couldn't get a stronger believer than me, I think. All the points that were mentioned earlier about the importance of CVCT, I think, are magnified in Asia. So first of all, there is an incredibly high burden of cardiovascular disease in Asia that, honestly, if you take a global view, it outstrips that seen in the Western world. The epidemic, virtually, of cardiovascular disease is growing faster in our area than other parts of the world. This is reflected by the growth in R&D in the cardiovascular clinical trials arena in Asia that's also growing at a tremendous pace in Asia, especially in countries like China and Japan, and that needs to grow in areas like Southeast Asia. So what I'm also pointing out is the immense diversity across Asia. And so far, there has not been any meeting that actually brings cardiovascular clinical trialists in Asia together to address these very important issues. So when you were kind enough to involve me in the global meeting, I immediately saw the need to have such a meeting in Asia, and eventually perhaps to combine to even have a true global meeting at some point. So thank you.
Thank you, Carolyn. Really happy to have CVCT reaching out in Asia. And just because this worked well, we thought that there are other regions of the world which need to join in the effort of global trials. And certainly Africa and Middle East is a place where not so many people think of when it comes to clinical trials. Yet this is a very large region with a good healthcare system and improving over the last few years. They start participating very significantly to trials, but certainly in registries. And learning from the experience in CVCT Asia, we thought that we should have a CVCT Africa and Middle East, and this is what is now planned, and we will have a meeting in April next year in Abu Dhabi with the same model and the same ethos and format than CVCT. So mainly we have a number of connection with learned and academic societies, and certainly moving up to Washington has been a great welcome from a number of societies which are listed here, and they all agreed to endorse the meeting, but as well to organize joint sessions. And hopefully we would like to reciprocate so that in the annual meetings of all these societies there may be a specific track about cardiovascular trials with potentially joint sessions. We are working in that in the future. And you see here a very short summary of what is really the specificity of CVCT. CVCT comes in two half times. The first half-time is the forum, where it is 2.5 days, discussion among experts with an audience, and this is typically addressing specific therapeutic areas. So we have sessions on trials on heart failure, trials in atherosclerosis, trials on biomarkers, and so this is specifically disease areas and dedicated therapeutic areas. And then we have a smaller, closed, on invitation-only meeting, which is called the CVCT workshop. This is 2 full days where everybody is in attendance, and we have a small selection with the same stakeholders, again, primary investigators, editors of major journals, experts from industry, and also from regulators, and mainly from the European Medical Agency and Food and Drug Administration. And this workshop, now different from the forum, addresses very generic issues about clinical trial science. So it's anything about methodology, statistics, applicability, approvability, etc., not specifically dedicated, although many of examples are coming from dedicated therapeutic areas. And whether it is in the forum or the workshop, discussion time is really very important. We start from the basics that all participants are knowledgeable about anything published in the area, so there is no lecturing, but mainly short presentation in order to raise issues which are discussed with a larger audience during typically an hour or two discussion time. So these are a very brief summary of the aims. On average, the meeting assembles 300 to 400 experts. These are really very importantly selected people, and the outcome is mainly directed to whoever has interest in trials, whether it is designing a trial, and this is a place where lots of new trials have been designed over the last few years, or running trials, or interpreting and publishing trials, or implementing the results of trials, and finally approving drugs or devices which have been submitted to these trials. We are partnering with a number of course directors, and these are listed here in this slide, which are dedicated to specific therapeutic areas, and these have been they have been extremely helpful. And you can see that they all span across a large range of therapeutic areas, but we do have also specialists into statistics. Stuart Pocock has been leading that over the last 2 years. Finally, we are partnering with a number of societies, as I've mentioned earlier on, whether in the United States or in Europe, and exchanging with them on this topic of cardiovascular clinical trials. 2 initiatives we are kind of proud of is certainly the Young Trialist initiative. Clinical trial training is not that frequently sought for by young cardiologists. They usually are fond of interventional or echocardiography or techniques, but we wanted to have many more of the young fellows being trained in clinical trials and become the future clinical trialists. So we are providing quite a large number of 20 to 30 grants to people coming from various parts of the world. And you see here the breakout of last year, young trialists, 37 of them actually had been welcomed in the meeting. And then another initiative is publications. We have the chance to have the editors of major journals on board on the one hand, and also young fellows and medical writers, professionals who are working on packaging anything important stemmed out from the discussions at the sessions in forum or workshop, and wrap it up into statement or position papers which has been published in major journals. And we have on the website quite a few publications which are actually co-authored by the speakers, including regulators, industry, and academics. So it's very important to have these position papers shared by the various stakeholders addressing the main issues discussed during the sessions. I have mentioned the second part of the meeting, which is the workshop, and this is very briefly summarized here, and I would like to show you in the next slide typically what are the topics. These are 2014. I picked them just at random, but it could we may have slides over the next year program, but it's just to show you that these topics are very generic, as much as discussing about how to interpret composite outcomes, or how to take into account patient-centered outcome research, and regional differences in trials, how to interpret them, how important these are for approval, the personalized medicine methodology trial, and so on and so forth. So this is just a few examples to show you the wide range of generic issues which are discussed at these 2 days closed meeting. And you see here the contributors who are again coming from these different backgrounds, academic, major regulatory agencies, and also industry. So much more can be learned about the meeting on the website, and I invite you to visit the website, and hopefully after this presentation we will hear some highlights from some of the topics which have been selected for you during this webinar. And I would like first to invite Dr. Borer to talk about the heart failure trials, the latest trials, and certainly trials about ivermectin, a heart rate slowing drug. He's been expert into this category of drugs, and especially now that after having been approved in Europe, this drug is now being taken over and has been recently approved in the United States. I would like just to mention that there will be question and answers after each presentation, or at the end of presentation, Joanne will let us know. So thank you again for listening, and Jeffrey, I would be happy for you now to talk about heart failure trials and more specifically about ivermectin.
Thank you very much, Fayez. The specific topic to which you asked me to respond, Aberdeen crosses the Atlantic, is this good enough? That's a sort of a provocative, open-ended topic, and I will summarize what I will be saying at the CVCT forum. If we can go to the next slide, please.
Well, now, Joanne, you need to take over the presentation from your side.
Okay, I see the next slide. Maybe I moved it forward. In any event, why are we talking about crossing the Atlantic with a drug that was approved first in Europe and developed in Europe, and asking, is just crossing the Atlantic good enough? There are reasons for it, because the environment, the regulatory and the therapeutic environment in the United States and in Canada differs from those environments in Europe. Why do we need a drug like ivabradine, which was approved in the United States specifically for reduction of heart failure hospitalizations? In Europe, it was approved for reduction in heart failure hospitalizations and reduction in cardiovascular mortality. Why do we need this kind of thing in the United States, where it was approved specifically to reduce hospitalizations? The reason is that the prevalence of heart failure in the United States today is about 5.75 million people, and it's projected to increase to about 8 million within the next 15 years, and about 1 million of those 5.7 million people with heart failure are hospitalized annually. Rehospitalization, primarily for heart failure, within 30 days of discharge from the initial hospitalization is 25%, and 50% within 6 months. Most recent data, for example, those presented at the Heart Failure Society of America last month, indicate that the American Get With the Guidelines program of the American College of Cardiology and the American Heart Association in the U.S. has really had very little impact on rehospitalization. Therefore, we need new approaches. And hospitalizations for heart failure account for 75 to 80% of the total cost of management of heart failure in the United States. Next slide, please. Now, one approach might be to optimize treatment before discharge from the initial hospitalization. That's a very laudable goal, but if patients aren't already on the drugs to be used after hospitalization when they enter the hospital, optimization at discharge is limited because of the difficulty in achieving rapid outpatient follow-up. That's a big problem in the United States. And if they don't achieve that, then there are problems. Drug toxicity without adequate warning, proscription of beta blockade or ivabradine until patients are stable without any definition of what stability is. And the urgency to reduce hospital costs by minimizing length of stay versus payment penalties for early readmission, which makes it very difficult to keep people around until you believe they're appropriately stabilized on drugs. Next slide, please. The effect of ivabradine on cardiovascular death or hospitalization for worsening heart failure crosses all the pre-specified groups that were studied during the trial. Older versus younger, male versus female, on beta blockers, not on beta blockers, etiology of heart failure, severity of heart failure, diabetes present or absent, hypertension present or absent. The only parameter which seems to be specifically associated with the benefit of ivabradine is heart rate. The higher the heart rate, the greater the benefit. Next slide, please. Now, in the United States, there have been some impediments to introducing ivabradine in clinical practice. This would speak to the fact that just bringing the drug across the Atlantic isn't enough. We have to deal with the problems. What are the impediments? One is inertia. There's no question that people don't like to change what they're doing, and that is a big impediment to introducing a new drug. Amgen does pre-certifications for physicians in the United States, which is a practical benefit, but overcoming the inertia is a big problem. Next, and perhaps more important, is the fixed belief that lowering heart rate will diminish cardiac output in heart failure. This just isn't true, and the belief persists despite the work of Jean-Claude Tardif and the other SHIFT investigators who authored the ECHO sub-study of SHIFT which showed that the slower the heart rate, the better the cardiac function. And also the work of Luigi Tavazzi, another SHIFT executive committee member, who did an IV study in hospitalized class 4 patients who clearly did not get worse as their heart rate slowed. Their hemodynamics actually improved. So we need physician education so that the concept that lowering the heart rate in people with heart failure will destabilize hemodynamics, to make it clear that this is not true. The requirement to maximize beta blockade before initiating ivabradine is an impediment. This is mandatory and it's appropriate because that's the way SHIFT was done. People had to be on beta blockers, maximally tolerated beta blockers, preferably the guidelines determined target doses, that is evidence-based target doses. And if it's done, but if that's done, it may preclude eligibility for the use of ivabradine. For example, I have a 96, she's now 98-year-old woman with long-standing tachycardia. She had a normal ejection fraction, but eventually developed systolic dysfunction, maybe from her chronic tachycardia. And now she's a potential candidate for ivabradine. But when I raised carvedilol to 25 milligrams BID, her resting heart rate fell to 66, which would be too slow for ivabradine. So we're going to repeat that a few times and make sure that it's really that low. Next slide. Next, difficulties with ivabradine use in the United States and perhaps elsewhere as well. There's confusion about pacemaker use. In SHIFT, we had specific rules about how often pacemakers could be functioning and what the default heart rate should be. This confounds the understanding of physicians about how pacemakers can be used in patients who are being treated with ivabradine. The labeling requirement is interpreted by many to indicate that ivabradine must be stopped if patients are admitted with worsening heart failure. That's the way it's interpreted. But that's questionable. In fact, we'll be presenting data at the American Heart Association meetings next week, showing that most people in SHIFT who were on ivabradine did not have the drug stopped if they were admitted to hospital for worsening heart failure, and their outcomes were identical with those in whom it was stopped. And in fact, they did well. So there's some confusion here. Also confusion about mortality effects. Note that the indication in Europe and in the United States differ, as I mentioned earlier. In the U.S., the drug was approved specifically to reduce hospitalizations. In Europe, it was approved to reduce hospitalizations and mortality. But the basis for that difference was the difference in the heart rate criterion in the two regions. Next slide, please. In the United States, the FDA made its decision based on the protocol design of SHIFT, which included patients with a heart rate of at least 70 beats per minute in sinus rhythm. And that's a very reasonable way to interpret the data. With that interpretation, mortality was reduced by 9% with ivabradine, which was not statistically significant. Next slide, please. But there was a pre-specified analysis at the median heart rate, which was 77. In that pre-specified analysis of SHIFT, those with heart rate greater than 77 actually had a highly significant reduction in mortality. Those with heart rate less than 77 didn't have any change. In Europe, those data were reviewed, and it was determined to do a post hoc analysis of a heart rate of 75, which might be easier for people to deal with than 77. And when that was done, there was a highly significant reduction in mortality for people who entered SHIFT with heart rate at least 75 beats per minute. So the drug was approved in Europe for a reduction in mortality, but for people with heart rate at least 75 beats per minute. Leading to some confusion in the United States about how the drug should be used. Next slide, please. So to conclude from all this, the introduction of ivabradine into the U.S. is an important additional to the clinical armamentarium for chronic systolic heart failure, but the introduction alone is not good enough. Outcome clearly will be improved, but the problem of heart failure will remain. And in the U.S., among patients with systolic heart failure, hospitalizations are frequent and not decreasing. Hospitalizations account for a large portion of the cost of heart failure management. Ivabradine guideline-based pharmacological therapy, addition of ivabradine to guideline-based pharmacological therapy, including maximized beta blockade, importantly diminishes hospitalizations irrespective of age, renal function, COPD, diabetes, heart failure etiology, blood pressure, heart failure severity. That's very important to know, but treatment optimization at hospital discharge is difficult. Several impediments that I reviewed have slowed introduction of ivabradine in the U.S., including confusion about mortality effects, about pacemaker use, and about cessation of ivabradine if the patient is hospitalized. With all these confounders, the primary strategy to increase incorporation of ivabradine, which is why I say that just moving it across the Atlantic isn't good enough. You have to use it and use it correctly. So the primary strategy to increase incorporation of ivabradine and with it to reduce heart failure, hospitalization, and death is physician education, because the data are really compelling. Thank you very much, Phibes.
Thank you, Jeffrey. This was a real great typical example of the issues which are discussed. You mentioned therapeutic inertia, you mentioned approvability, you mentioned applicability of what is true in Europe to the United States. You mentioned approvability issues. So these are real great examples of what is CVTD all about. So thank you so much, and I hope we will have questions later addressed to you. I'd like to hand it over now to Bert, who is going to be discussing the use of new mineral oxide receptor antagonists and ongoing trials in this area, but also as well issues related to the use of renin-angiotensin system antagonists, which are hyperkalemia and worsened renal function, and the recent development in new binders of potassium and typically trials which are addressing the use of these medications to optimize therapy of renin-angiotensin-aldosterone system. Bert?
Hello. So I'm going to briefly talk about potassium lowering drugs, and then about mineral corticosteroid receptor antagonists, the new one, the non-steroidal. Let me just briefly talk about the new potassium lowering drugs. This is a very opportune time to talk about it, because just last week, one of them, Potassium, was approved by the U.S. FDA for clinical use, and in May we expect the second new drug, ZS9, to be approved. Now, I think we've learned an awful lot over the last year about the risks of hyperkalemia. A lot of us pay attention when potassium is 5.5 or more, but recent data suggests that if you have comorbidities such as heart failure or renal disease, and you're over 65, then a potassium of 5 is associated with a significant increase in risk, a 1.6-fold increase in risk. So hyperkalemia may be far more important than we ever thought. The other thing we know is that a lot of patients are on suboptimal doses of RAS inhibitors, especially MRAs, due to the fear of hyperkalemia. And often, when you start an MRA, such as spironolactone, about a half of the patients somehow discontinue it over the next 6 months or a year due to a rise in potassium. So these new potassium-lowering drugs, both Potassium and ZS9, will, we believe, have a great impact. Both have been shown to be effective and safe. Both have completed their pivotal trials, and we know a little bit more about Potassium because the FDA has approved it. We know its label. We'll know more about ZS9 next May. But both of these new agents, I think, will open up a whole variety of new clinical strategies and new clinical trials where we enable RAS inhibitors and show that because of these agents, we can increase the number of patients getting an MRA in heart failure and even target doses of a RAS inhibitor. So we're going to discuss some of the design of these trials and what the implications are of of these availability of these new agents. So I'm going to switch now and talk about the new mineralocorticoid receptor antagonists, the nonsteroidals. There are a number of them in development. We know that our old friends, spironolactone and eplerenone, have been very effective, and Phibes and I have worked over the last decade or more in various trials of RALS, Ephesus, and recently TopCat, looking at the role of spironolactone and eplerenone. And as you know, for systolic heart failure, they're a class 1 indication. The role in heart failure and preserved ejection fraction is more controversial, but the Canadian guidelines have just recommended the use of spironolactone in heart failure and preserved ejection fraction based upon the sub-analysis of TopCat in the Americas. But the availability of new agents holds even greater promise, because a lot of the lack of use of mineralocorticoid receptor antagonists, as I said previously, is due to the hyperkalemia and the fear of hyperkalemia. We had the opportunity in the ARCH trial to compare spironolactone to this new nonsteroidal agent finerenone, which has different properties. It's very, very selective for the mineralocorticoid receptor, and it is very specific, whereas spironolactone is very tightly bound but not very specific, and we have the usual side effects of gynecomastia and breast pain, which we don't have with the more specific agents. Eplerenone, on the other hand, is rather specific, but it's not tightly bound, and it's less effective than spironolactone. The new agent finerenone combines both. It is very tightly bound and very specific. And in the direct comparative trial that we did with Phibes Inaud and myself and others, the ARCH trial, we had equal efficacy as using the biomarkers BNP and albuminuria, but it appeared to have significantly less hyperkalemia. This was then followed by the ARCH heart failure trial, which was recently presented at the last ESC, and there we compared it to eplerenone. And in that trial, the efficacy, at least regarding BNP reduction and hyperkalemia, seemed to be somewhat similar to eplerenone, but strikingly, the patients randomized who had CKD and heart failure to finerenone had a striking reduction in mortality compared to eplerenone. Number of new trials. There are 3 large-scale trials underway, or just about underway. One is a 4,000 patient trial in patients with diabetic nephropathy, which Dr. George Bakris and Dr. Philippatris from Greece are running. There's another trial in 6,000 patients with renal disease who have increased cardiovascular risk with cardiovascular outcomes. That's 6,000 patients, and Dr. Louis Rilopi and I are running that. And then there's a third trial in patients with heart failure, with CKD and or diabetes, which I am involved in with Dr. Marco Metra and Dr. Philippatris. So these 3 major trials have just begun or on just about to start, and really will have, we think, an impact in how we think about renal disease. And there are many other opportunities in the future for trial design with this new agent. So I think this is going to be an exciting CVCT where we have the opportunity to think about how we use all these new strategies. So I'm going to give it back to you, Phibes.
Thank you so much, Bert. And again, a very important and great example on how it is important to gather in the same room people from various backgrounds. This is typically a situation where we have started with this mineralocorticoid receptor antagonist in heart failure, and it stemmed out a number of issues related to hyperkalemia. From now, we have this hyperkalemia therapy agent on board, and thinking of designing trials in order to help optimizing the use of mineralocorticoid receptor antagonists. And then from this kind of interaction also, we had these ideas of getting out from heart failure to diabetes and CKD patients, where these diseases may also benefit from miroopathy receptor antagonists. So it is really by interacting and building bridges among different disciplines, heart failure, nephrology, diabetology, that we can create this new innovation and momentum for new trials. So thank you so much for this. And now I'd like to share the screen and have Carrie Lam address you about her specific talks about heart failure and phenotyping heart failure and how it is important to segment the disease in order to select patients who are most likely to respond, and the trials using very specific designs in personalized medicines are now coming into the cardiovascular area. They have been long, very active and popular in oncology. And by the way, we are having oncologists at this meeting this year in order to learn from them how to run precision medicine trials. And Carolyn is a specialist on heart failure with preserved ejection fraction, which is a very huge unmet need. But I know that she would like also to share with you some of her thoughts about the Asian perspective as well. Carolyn, please.
Yes, thank you, Fayez. So I would like in the next few minutes to really offer a teaser of how important it is to individualize and to think about variability among patients with heart failure, especially across the globe, and how this would impact our therapeutic approaches. So I'm not going to give it all away, but just sort of give a quick picture of how different things can be in Asia and the things that we have, the tools that we have to pursue precision medicine in Asia. So I humbly come from Singapore, so I feel very, very privileged to be part of this discussion. And in the next slide, just to let everybody know where Singapore is, because it is really a dot on the map. And this little dot, our little red dot, contains almost 6 million people with a unique racial admixture of Southeast Chinese, Malays, and Indians. It is also very interconnected and very amenable to population-based research. Because it's in the center of, in the next slide, what I would call the epidemic of cardiovascular disease in Asia. This is why we are uniquely poised to study and also to host CVCT Asia meeting. So this puts the global perspective, I think, on heart failure, which we've all been talking about. You've already heard about the prevalence in the United States of 6 million, and the incidence is as stated. In Europe, here are the corresponding numbers of prevalence of 15 million and incidence also of 500,000 a year. But look at just Southeast Asia alone, in which the prevalence of heart failure is estimated at 9 million just in Southeast Asia, and the incidence much higher of 1.5 million. So this really represents the burden of disease that's here, and this again is not even including China and Japan. In the next slide, these are the impetus for us to have set up, in the next slide, a network to study this further, but just looking, sorry, if you could go back one slide, at the published research that shows the differences between Asian and American acute heart failure, both in the ADHERE registry in the US and in Asia Pacific. You'll notice immediately that there are higher prevalences of dyspnea, rales, and there's a higher prevalence of usage of inotropes, for example, in Asia. But look at the low usage of echocardiography, for example, to determine ejection fraction in Asia Pacific, only in 50%. Next slide, please. And yet, there is a longer length of stay and higher in-hospital mortality in Asia Pacific compared to the United States. And hence, in summary, here in red, you'll see in Asians, we get heart failure. Remember, this is end organ failure at a younger age. We're more symptomatic. Ejection fractions only assess in half of the patients. There's more inotrope use and ventilation, less evidence-based medication, and poorer outcomes. And the next slide, which provides the rationale for studying this in a prospective fashion in the Asian Heart Failure Registry, which is aiming for 5,000 patients with heart failure reduced ejection fraction, adding on another 3,000 patients with preserved ejection fraction. The next slide, please. This slide shows all the sites in the network that are recruiting patients with heart failure. And if you'll just tab through, just to emphasize that China and India are all involved in this combined effort. There are some unique characteristics about this registry, which I will skip over. Happy to provide details at the question and answer, but here is the teaser. These are the preliminary results of the first 2,000 patients of 5,000. And another teaser is that we are actually completing the recruitment of the 5,000 patients by the end of this year. And so I am very excited to be sharing some of the thoughts at CVCT, the global CVCT meeting, when we are interacting with counterparts from the US and Europe. But here, just the first 2,000 patients, you'll see again reiterating the fact that we're at least a decade younger in Asia when we present with decompensated heart failure. And while being of a lower BMI, there is a strikingly high prevalence of diabetes, especially in the Southeast Asian countries, especially Singapore and Malaysia, where you'll see diabetic prevalence is almost 60% and a very, very high prevalence of hypertension as well. And if you move ahead, of course, this brings the questions of why are Asians so predisposed to early diabetes and early heart failure. We formed a network to study this further, and especially to further our look at precision medicine. And if you move to the next slide, this is a very important initiative in Singapore that really combines the only two national heart institutions, multiple biomedical research institutions, and academic institutions to look at this in more detail, to look at the Asian phenotype and precision medicine in cardiovascular disease. And if you look, the next slide illustrates this aim, this platform, which is composed of 3 themes that you can see arching horizontally. The first is imaging, the second genetics, and the third detailed biomarker studies. And in the 3 vertical pillars, you'll see that why we are now leveraging the human cohorts and extending the research to involve large and small animal models as well. In the imaging, we are actually deepening it not just to include echocardiography, but now to include MRI imaging and state-of-the-art magnetic resonance spectroscopy, including cardiometabolic imaging with phosphorus-31 and hyperpolarized carbon-13. In genetics, we are moving from genome-wide association studies to whole genome sequencing and the study of epigenetics. And in biomarker work, we're really going in depth with a whole array of biomarkers, but not just in humans, but with parallel biomarker work in our large and small animal models. Next slide, please. So in this sense, we are trying to address this need for further research and development in Asia. Phibes has parallel studies going on in Europe, and you can see that immediately in a CVCT meeting, it is the ideal opportunity where we can discuss how these various large databases can be synergized to answer even more important questions of personalization in different parts of the world. This slide actually just shows that ascent in R&D development in Asia. You can see with the largest growths in China, in South Korea, in Singapore is there as well, in Japan. And in the next slide, this was, of course, the impetus for us to bring the CVCT meeting to Asia last year. And this was the inaugural CVCT Asia meeting in 2014, which I'm proud to say went really well. Other than a robust exchange and a great attendance even for the first meeting, we also had publications. I just show one in the next slide that talks about, of course, the area that I am chiefly interested in heart failure preserved ejection fraction. This is one publication. We have another in the pipeline specifically talking about heart failure in Asia and the different initiatives there. And if you could allow me to just end with a plug for the next CVCT Asia meeting in the final slide. That's occurring next year, and this is in July, where we will really take this forward in even more robust conversations. So thank you, and over to you, Fayez.
Thank you, Caroline. Great teasers. And one of the topics you have highlighted is the diabetes and the distribution of diabetes in Asia. Certainly true as well in Middle East. And one of the highlights of the next CVCT in Washington, upcoming December, is also the session dedicated to overweight drugs and diabetes hypoglycemic agents. And this has been an area of the last few weeks, actually, where progress has been tremendous. And actually, the great news is that for the first time ever, we have a diabetes drug which prevents cardiovascular outcomes, including progression to heart failure, and this is the AMPEREG trial, and we'll have a full session dedicated to these initially designed trials to explore cardiovascular safety of new anti-diabetic drug, and then some of them went to superiority, and we will have an overview of all these trials and whether it is time to revise the guidance of the Food and Drug Administration about the needs for new trials, cardiovascular protection trials in diabetes. We'll have this session with the cardiorenal division. We'll have also the metabolic division, FDA people attending, and of course the European agency, as well as the main sponsors of the main trial so far and the main primary investigators. So this is going to be another hot topic discussed at the CVCT. I just wanted to get back to these importance of regional differences, and certainly you have done a very good job showing how much it is important to synergize and having these global trials take into account differences among regions. But regional differences may also play negatively, and I would like to call upon Bert, if he's still in line, and share his experience, bad experience with the TopCat trial, and how typically regional differences into conducting trials could actually have negative impact onto trials. Bert?
Well, so regional differences have been commented on in several different publications over the years, but we certainly need large-scale trials in cardiology, and because of the large scale, often we need a multinational participation. But it comes with a price, and there are clearly differences among regions. So I will go back a little bit to some of the work we did with Fayez in emphasis, where we looked at the role of eplerenone post-myocardial infarction, and we had a reduction in total mortality and heart failure hospitalizations. But then when we analyzed using propensity analysis, the results from Europe, Central Europe, and America, we found there was an identical risk of mortality, but there was a tremendous difference in hospitalization for heart failure. Our friends in Europe had a much lower rate of hospitalization for heart failure than we did in the United States, and I think that may reflect our push to get people out so quickly, whereas they have a longer time to take care of a lot of the comorbidities. The most recent experience we've had is from TopCat, which many of you are aware of, where we studied the role of spironolactone in patients with heart failure and preserved ejection fraction. The overall results were not significantly better for spironolactone, but when we looked, half the patients came from Russia and Republic of Georgia, half came from the Americas, which is Canada, the U.S., Brazil, and Argentina. And when we looked at the placebo event rates, the placebo event rate in Russia and Georgia was about 1/5 of that of in the Americas, and not compatible to what we know about heart failure and preserved ejection fraction from Carrie Lam studies and many other randomized trials, whereas in the U.S. it was compatible. In Russia and Georgia, there was no effect whatsoever of spironolactone, significant reduction in our primary endpoint of cardiovascular mortality and hospitalization for heart failure. And when we looked at differences across Russia and Georgia and the Americas, in the United States and the Americas, if you received spironolactone, there was a marked increase in potassium and a decrease in blood pressure. This was much, much less obvious in Russia and Georgia. So not only do we think that patients from Russia and Georgia didn't have the syndrome of heart failure and preserved ejection fraction, as we understand it, we're not even sure patients received the drug. So geographic differences are very, very important. I'm not saying we shouldn't do multinational trials, but if we do it, I think we have to carefully verify inclusion criteria and patient adherence. And I think many people, because of our experience, are re-looking at how they do clinical trials multinationally. I'll give it back to you, Phibes.
Thank you, Bert. This is actually a topic which we revisit every year or every other year at the CVCT, because it has been very hard and very central in the interpretation of many, many trials over the last few years. And getting back to Asia, Caroline, it is just impressive, your one-stop translation platform and the large databases you are connecting, and certainly connecting with the rest of the world. My question is whether these institutional efforts are bridged with some industry collaboration, how much you collaborate with industry, and how much these registries will be ready for some time to have trials embedded in the registry. These are two different questions. Caroline?
Oh, that is tremendous questions, Phibes, and really spot on. So the registries are funded by a academic with industry partnership, which I think is very important. It's practical, it makes things feasible, and it really is a win-win for both sides. So both registries as well as networks are primarily funded first by governmental academic funding, but then we enter partnerships with industry. So that is using it as a registry, which is purely observational. But you are absolutely spot on that the long-term dream is to be able to do registry-based trials. I think that is the way to go. The TASTE trial, of course, was one example that everybody looked at and admired at how a well-done trial could be done much less expensively than they are done now. And obviously this needs to be grown. So I am very, very much for that idea and working towards that.
That's really great to hear, and totally in line with the very strong recommendation from Rob Califf, who we will be very pleased to greet at the CVCT meeting in Washington, who has been at the meeting at CVCT with other people from other stakeholders advocating for large, simple trials in order to streamline trials and get as much as we have heard from Dr. Gibson, from the head of NHLBI last year when he addressed CVCT. I like his expression, getting most science out of $1, so that we maximize knowledge production. And by the way, I just wanted to highlight the critical, important role of the NHLBI, who are very heavily attending the meeting and participating, so that the meeting encompasses not only industry trials but also institutional trials. And this year, from the NHLBI, we will hear about the result of the SPRINT trial, which is yet another area which is covered at the meeting, which is the hypertension therapy, where the trial has been highlighted recently, although we don't know the details of the result, as setting new standards for antihypertensive therapy and lowering the target blood pressure under treatment below 120 millimeters of mercury. So this is going to be also another big highlight of the session. I would like now to turn it over to Joanne to close out the session and thank all the attendees, and hopefully welcome many of you to attend the CVCT meeting in Washington early in December. Thank you so much.
Well, thank you, Dr. Inaud, and thank you to all of our speakers today, Dr. Pitt, Dr. Borer, Dr. Lam Suping. This is going to be quite a conference, and it's wonderful to be able to offer a sneak peek today. Within a few hours, at least by tomorrow, these recordings will be on our website, and we'll send out a note with the link, and you all can feel very confident sharing this with your colleagues, and that will include a link for registration to the conference as well. Thanks so much, everyone. Have a lovely day.